So, starting chapter 30, let me first point out from our exam study guide that there are two questions from chapter 30. They're both multiple choice. One's on glucocorticoids and one's on therapeutic response. So keep that in mind as we look through this chapter. Also, pay attention to the outline for this chapter because I put a lot of more information in the beginning of this. So I start, and literally it's outlined so you can follow both of them at the same time. So read through the chapter outline and then my teaching notes before you go scroll through the chapter or do them at the same time. So when we talk about that endocrine system, we're looking at that maintenance of physiological stability. That's that main goal. You have to understand that we have the endocrine system will accomplish this task of physiological stability despite the constant changes in the internal and external environment. Every cell and organ in the body comes under the influence of the endocrine system, which is a big deal. It communicates with nearly 50 million target cells using chemical language called hormones. Hormones are the large group of natural substances that cause highly specific physiological effects on the cells of their target tissues. They're secreted into the bloodstream in response to the body's needs, and they travel through the blood to their site of action, which is that target cell. So, if you need a little bit of reminding on how that works, read through that beginning part. Keep in mind that the hypothalamus controls the pituitary gland for this chapter and function together to govern all body functions. When we talk about the pituitary gland, it's made up of two distinct lobes. I'm not going to ask questions about, but whether it's anterior or posterior, but I'm just reinforcing what you had in A and P. So the adenohypophysis, which is my anterior pituitary gland, and that neurohypophysis, which is the posterior, they're individually linked to and communicate with the hypothalamus, and each lobe secretes its own different sets of hormones. Those hormones are either water or lipid soluble. Those water soluble hormones are protein based substances such as catecholamines, norepinephrine, and epinephrine. And the lipid soluble hormones consist of steroid and thyroid hormones. The other big thing you have to understand about the hormone system is the negative feedback loop. So this activity of the endocrine system is regulated by a system of surveillance and signaling, which is usually dictated by the body's ongoing needs. I love that, but my body's always responsive, always sending signals out. That hormone secretion is commonly regulated by the negative feedback loop. That's explained by using the fictional example when a gland X releases hormone X. This stimulates the target cells to release hormone Y. And when there's an excess of hormone Y, gland X senses that excess, and I decrease the release of hormone X. So it tells your body when to release these things. I think that's absolutely brilliant. Great table on 477 for hormones of the anterior and posterior pituitary. On our pituitary drugs, we're really looking at three specific drugs. I think that was listed way up here at the very beginning. So these are our three specific drugs for this chapter. When we, I'm going to scroll down and look at those three drugs. Um, so on our three drugs, I'm going to pull over my outline here. We talked about that negative feedback loop. We're looking at these three different drugs. We will take them for specific reasons. So we're going to take this first one, the cosentropin, as if I have adrenocortico insufficiency. That one's not on my list to memorize. If I take the next one, somatotropin, which is on my list, it's a human growth hormone, so it stimulates my skeletal growth in patients that need that. And then my third drug here is octreotide, which helps alleviate symptoms of carcinoid tumors that I get from a secretion of VIP. And there's a really good definition of this in our book that we'll look at in class. And then my last one is my vasopressin or desmopressin. Vasopressin and desmopressin are used to prevent control of polydipsia, that excessive thirst, polyuria, and dehydration in patients with diabetes insipidus. If you remember, we mentioned desmopressin in conjunction with individuals with nocturnal enuresis. So it's a good treatment option for that one. Okay, it says that down here. Let's look at some of my contraindications. Contraindications are specific, so if they don't need the medication, they won't get that medication. They're used also very cautiously in patients with chronic or acute illnesses like migraine, headaches, epilepsy, and asthma. Then I do have two tables, excuse me, one table that looks at all of our medication here for the side effects. So let's go over to that. That's on my 477. Excuse me. We want to look at some of those common adverse effects. So some of my adverse effects for my octreotide, or some of my adverse effects for my desmopressin here. Notice those. And I'm not going to ask you about the growth hormone. That's pretty rare to give that one. You'll see these other two more frequently. And then noting some of our interactions on this table here. Specifically, if you look at what's going on, it will decrease the desmopressin effects typically of those. And here's our three drugs. So my first one, my octreotide, we mentioned what that one did. Let me see if I want to tell you anything specific on that one. That octreotide is useful for alleviating those symptoms of carcinoid tumors stemming from the secretion of VIP, including severe diarrhea, flushing, and life-threatening hypotension. It's also used in the treatment of esophageal varices. I've seen esophageal varices on patients that were alcoholics and had vomited quite a bit. It is contraindicated in patients with a known sensitivity to it. It can also impair gallbladder function, so it needs to be used in caution with patients with gallbladder issues or renal impairment. It can also affect glucose regulation, so severe hypoglycemia can occur in patients with type 1 diabetes. It can cause hyperglycemia in patients with type 2 diabetes. So either one of those, we'll want to note that we want to monitor those patients, any patient with type 1 or type 2 diabetes, for their glucose levels. And then if I take ciprofloxacin, which is an antibiotic, it can enhance the QT prolonging effects of this medication, which could give me some cardiac disturbances. A benefit is that I can give it IV, intramuscular, or subcutaneously. Then if I scroll down to my next one, somatropin. Somatropin is that growth hormone that we can give from inadequate endogenous growth hormone secretion, meaning my body's not giving enough of that one. I am not going to ask you a question on this one, but you might get one on HESI or NCLEX, so that's why it's covered here. Some of those adverse effects include headache, injection site reactions, muscle pain, hypo or hyperglycemia again. So I would cue in on that hypo or that hyperglycemia. And then the third one is that vasopressin or DDAVP, desmopressin or vasopressin. And we mentioned earlier what those are used to prevent, control that polydipsia, that excessive thirst, or polyuria or dehydration. Also, we can use that desmopressin in our patients with nocturnal enuresis. And then scroll down to the end of the chapter where we talk about the assessment. Think about what we're wanting to assess with these patients before we use them. And they're mentioning the two big ones. ECG, so echocardiogram, so I know what my patient's heart rhythm's doing. Glucose levels would be the other really important things to mention. And then if I scroll down to implementation, make sure that the patient understands they need to report anything that's abnormal while they're going through treatment. And then evaluation is it working? So am I using, whatever I'm using this drug for, is it doing what it's supposed to be doing for those medications?